Thanks to Manos and Manos for the invitation, and I'm happy to present something about that we have done on the ESA board and all the ESA members, and thank you for that. So I'm only the presenter, and the main work has been done by others. These are my disclosures. Thanks again to all the surgeons involved. So it's 40 surgeons. They did a great job on writing, on answering all those questions that were quite a pain in the neck sometimes. So what do we currently know? I think we have a good overview already. What we know that we know little. We have the current classification is the Rockwood classification, which we should all know. But then there is also a Bannister classification and the Tossi classification, which I still hear from the radiologists. So there's quite some stuff. And as you can see, Rockwood, he published his classification just as a book chapter, so it has never been validated. Then ISACOS with Knut Beitzel, they tried to make a difference in the grade 3 sprains or AC joint dislocations, and they divided it into A and B. I think you already heard about that. But do they need an operation, the 3 Bs? So there are a lot of open questions also about radiographic measurements. What radiographic measurements shall we do? The GACA angle, which is quite difficult to measure, or like it needs a lot of manpower, and then the AC-DC, sounds like a band, but it's also like not that easy to measure if you don't, if you haven't published it yourself. And then we don't know what is acute and what is chronic. Is it 3 weeks? Is it 6 weeks? What's really a acute AC joint dislocation? And it has been published by Flint, which was just a survey. And as you've heard, we know that there are many operations. You can do anything you like, almost to reconstruct the ligaments, and even up to a hook plate. And also regarding post-op rehabilitation, we just heard about it. Do we need a sling? Do we need an abduction brace? How much is the range of motion? When should we start range of motion, weight bearing, and when? So these were the questions. How did we try to find answers to these questions? This was the so-called DELPHI assessment, which is considered to be the state of the art to find a consensus. There are different rounds, starting with round 1, which is an open-ended questionnaire, then round 2, where you summarize from round 1, and then 3, 4, 5, or like condensing everything. And it can go up to a few rounds, up to 100 even. So over 66.6%, 2/3 is considered consensus. What did we do? So everything started in 2018 with the ESA closed meeting also here in Athens. So the circle is closing. And then we had the online questionnaires around 2, 3, and 4. And then during the ESCA specialty days in November 2019, last year, we tried to conclude the remaining questions that were still inconclusive. And we had the discussion, and now we did the analysis. So this is the first time we present the results. And then there will also be published in KSSTA, and we will talk about it at the ESCA conference. All right. So just to give you an overview, this is the panel. So most of us operate, these are the treated, sorry, not the operated, between 10 and 50 AC joint dislocations. That is treated, operatively and conservatively, both. Huh? And these are the operated AC joint dislocations. So you see most of us operate up to 30. So more than 30 is really, it's not a lot of surgeons that operate more than 30 a year. To give you an overview, this seems a little bit confusing. I'm sorry for the numbers at week 4 and 6. This is just to show you how it developed, how a consensus is developed. I consider a case acute if it is less than 1 week. Nobody consented in round 2. So here on the left lower bottom, it says round 2. And then most of us said, okay, under 2 weeks or under 3 weeks. And then in round 3, it was more. And then in the end, we came to a consensus that I consider a case acute if it is under 3 weeks. So that's the big blue thing that you can see there. Where did we find consensus? I will just show you the literature or the questions where we found a consensus, and also where we do not recommend. This is for basic workup. So on the left side, you can see the radiographs. We consented on doing true AP and panoramic view without weights, and no additional imaging, no MRI, no CT, no sonography. On the clinical tests, scapular dyskinesia, which is also part of ISOCOS statement for 3B, and then the horizontal override and crossbody, pain, and not recommended is the AP test. For testing horizontal instability, as said, the horizontal override, no specific radiographs, so even modified Alexander are not recommended by the panel, and also MRI, CT, and sonography for the horizontal instability are not recommended. And also not recommended is, as I showed you before, the AC-DC or the modified Alexander view, and also the AC joint width. Looking at literature, we found that the true AP is not supported by literature, but the rest is really supported also by literature. So it's not just an expert opinion, it's really supported what is already out there. And regarding the chronicity, we all consented, or most of us consented, was like 95%, that acute is under 3 weeks. And over 3 weeks, there is a subacute stage, I will come to it, and then 6 weeks chronic. Regarding the classification, we're not happy with the Rockwood. We all know that it's not really the inter-observer reliability is not great. But it is sufficient for us to work with and comprehensive, also with a grade 3B, but not recommended is Bannister and Tossi. And this is also supported by literature. So then we also asked, how shall we treat the patients conservatively? And these are the recommendations that the panel had. So immobilization is simple sling, no abduction pillow, just simple sling for 3 weeks. Then we start full range of motion, and then we start weight bearing at weeks 7 to 8. Full return to overhead activities. This is a conservative treatment at week 12, and full weight bearing at 3 to 4 months. At week 12, that's why there is the cross on the lower part, is the minimum time considered until failed. So we need to give our patients 12 weeks time until we consider conservative treatment as failed. When do we switch from conservative to operative? If we have consistent pain. We did not consent on horizontal override, the Rockwood grade, or discomfort. Regarding the operative treatment, as I said, under 3 weeks is acute, and the 4 to 5 weeks is the subacute stage. Regarding the operation strategy, we consented that the arthro-assisted suspensory device, like the dog bone button or whatever is out there, is recommended. And then we should always address the AC joint caps. I think we heard about it before. That was really a strong recommendation, but no routine AC joint resection. We shouldn't do that in a routine. And then regarding the tendon grafts, like we heard from Frank before, no graft augmentation in acute cases, but graft augmentation in chronic cases. And which one? We take the semi-T wrapped around the coracoid, knowing that there is a lot of complications out there. And this is also supported by literature. So this is the postoperative treatment. It's almost the same as the conservative, to make it easy so we don't have to go through this. So up to 6 weeks, immobilization, just passive range of motion, no active, and then we gradually go into full weight bearing. Pain is always a criterion to return to full activity, and this is other than time, we always look at pain in the AC joint. And this is it. If you have any questions, please ask them, and thanks for being here.